Thank you, Carol, and I'd like to also extend my welcome to all of you for being here. The title is, as you see, it's Perspectives of an Aging Researcher on Musculoskeletal Aging. And I sometimes tell the people that I'm seeing in the clinic that the only advantage of being an older physician is I've had most of the things that you've had. Musculoskeletal aging is what you can see when you look at a group of us who have gray hair. And what you can see is our skin doesn't look like it did, and our hair doesn't look like it did, and everything else that you can see externally is musculoskeletal health. We can't see our lung function decline, we can't see our renal function decline, but we can see our musculoskeletal status decline, and it's basically the big three are listed here: osteoporosis, sarcopenia, and osteoarthritis. And I want to touch briefly on all of those, starting with osteoporosis. And this is what osteoporosis is. It's loss of bone mass, loss of bone microarchitecture. I often describe it as a scaffolding. And as we age, the pipes of the scaffolding get smaller and the cross struts get cut. And as a result, the bones are no longer as strong. Sarcopenia is simply a $95 word for age-related muscle loss. And I show this here as the weightlifters. Here's a young person lifting weights, here's the older person lifting weights. Look at the difference. My personal experience with this is that 50 pounds of birdseed weighs a lot more than 50 pounds of birdseed used to weigh. And so that's my experience with sarcopenia, and osteoarthritis is basically a degenerative disease of the articular cartilage, the smooth surfaces that allow our bones to run together, and I often depict that as 60,000 miles on the tires. And these things often occur together. So as an individual, we can have osteoporosis, we can have sarcopenia, we can have osteoarthritis, and the intersection of those, if we're unfortunate enough to have all of those, is particularly bad. And that it can lead to falls, and those falls can cause injury, and those injuries can include fractures, and the big bottom line is that that can impair our independence and our ability to live together. But you might say, I'm more worried about cancer, or I'm more worried about dementia, or I'm worried about heart attacks. I'm not worried about my bones and muscles. And as such, I share this with you. The third leading cause of death in the United States is unintentional injuries. So this is not an inconsequential problem, and falls are what cause those injuries. And about 1 in 4 of us over age 65 are going to fall this year. And here's Wisconsin data from the CDC. 27% of us fell in 2020. That caused 1,635 deaths. Our death rate is the highest in the nation. This is one of the things that you don't want to be first with. I don't know why that is. Is it because we have better reporting in the state of Wisconsin? Is it because we drink a lot of beer in Wisconsin? Is it because we have winter in Wisconsin? I don't know, but we're number one, and that ain't good. And falls cause us to break. Almost 90% of so-called osteoporosis-related fractures are because we fall over. And this is common. These are data from Medicare. In Wisconsin, this year, 1 in 20 women is going to sustain an osteoporosis-related fracture, 5%. And about 2.5% of men are going to fracture this year. This is a whole lot of us. And the numbers that are often out there is that the mortality, in Wisconsin, 30% of us die in the year after we break our hip, and 20% of us die after we have any fracture. And you know, death is not good. But the big deal here is it impairs our mobility. Half of us, after we break our hip, do not get back to our prior level of mobility, and 1/3 of us are in the nursing home. And I don't know anyone with gray hair who thinks that moving to the nursing home is an improvement in quality of life. And this is a survey that says that's what we worry about. What's our biggest concern about aging? Loss of independence and loss of mobility, and those are the same words. And that's the biggest concern about aging. And all of us have things that we want to do. We want to play with the grandkids. We want to see the boys. We want to volunteer. We want to read. We want to do something. And loss of mobility, falls, fractures, threatens that. And here is a wonderful resource that I want to share with you. It comes out of New Zealand. They've really got it right. It's written for the level of Jane Doe and John Smith. Love your independence. And it talks about falls. It talks about things to maintain your independence. And if you Google love your independence, it's the top hit. Go to that, read it. It's a wonderful resource. All right, so what causes this to happen to us with advancing age? What causes osteoarthritis? Well, it's basically wear and tear. There are risk factors for it: being older, being female, being overweight, having prior joint injury, repeated stress on the joint, how you picked your parents, deformities of the bone, and some metabolic diseases cause osteoarthritis. And unfortunately, there's not a lot that we can do to prevent the progression of osteoarthritis. And this is just a pyramid of the management of it. We start down here with non-pharmacologic things like weight loss, exercise, PT, oral medications for pain, injections in the joint, narcotics, and finally surgery after we've failed everything. So the obvious question then is, how about glucosamine chondroitin? I've heard a lot about that. Does it work? The short answer is, I don't know. This is a systematic review of almost 4,000 folks with knee OA, and it wasn't overly positive. So there's no definite data that it works, but there's also not definite data that it doesn't work. And there's so many different types of glucosamine chondroitin, there's different doses, and we're treating different problems. So as I said, I don't know, and if you want to try it, I think that's fine. And I have patients that I've cared for. Some of them swear by it, and some of them swear at it. I think it's worth a try. And if it helps, great. If it doesn't help, stop. Well, then how about surgery? And I share this just to make the point that imaging isn't going to tell you if or when you need a surgery. These are big surgeries. It's not like getting a haircut. And this is a lady that I saw just recently, and this is what a hip is sort of supposed to look like, and her hip over here is totally destroyed. And she's not ready for surgery. So the surgical decision is when you say, I'm not happy living this way, this is affecting my quality of life, then that is the time to think about surgery. Moving to the causes of osteoporosis, it's a multitude of things. I'm not going to go through it in any detail, but it's changes in hormones, inflammation, inadequate nutrition, sedentariness, toxin exposures, and that leads to the reduced bone quantity and quality that I showed you before. And I would suggest to you that sarcopenia and osteoporosis are the same disease pathophysiology, simply expressed in different tissues, bone and muscle. So we can change osteoporosis to sarcopenia, we can change bone to muscle, and it's the same thing. Now, dogma says that things get worse with advancing age. That might be true, but we're wrong here, that this says this is just a linear decline in both bone mass and muscle function. We peak somewhere around age 25 or 30, stay stable for a while, and then it's this linear downhill slope. It's my bias that that's too pessimistic, and it basically says you're getting old, nothing to do. I think dogma's wrong. And there are data out there documenting that this is not a linear reduction, but rather it's a stepwise reduction in both bone and muscle. And it's because stuff happens to us. So we're putting along here at age 50 or 55, and then we get pneumonia. Boom, down we go. We never quite come back. And then we put along at a new lower level, and then we have a hip replaced. Boom, down we go, and we never quite back. And then we get a bladder infection, and this cumulative things ultimately lead to to getting us down here into trouble with falls, fractures, and troubles with independence. What that means then is that after something happens to us, we need to emphasize both physical and nutritional rehab after illnesses and surgery. So, okay, stuff happens to us with advancing age. We lose bone mass, we lose muscle function. What can we do to retain our independence? And the first thing is exercise. And I would suggest to you that Mark Twain had it wrong. And that he said, whenever I get the urge to exercise, I lie down until the feeling passes away. That ain't exactly right. And furthermore, what's the best exercise? It's one that you will do. I don't care what it is. And it works. It's never too late. There are data in the nursing homes, 90-year-old people can become stronger. It's almost too good to be true. It improves muscle and bone strength, sleep quality, reduces blood pressure, reduces anxiety, long-term lowers the risk of heart attack, stroke, diabetes, dementia, cancer, and obesity. It helps us remain independent. It reduces falls risk. That's just too good to be true, but it's not. It works. Great, we're all doing it, right? No. These are the percentage of individuals over the ripe old age of 65 who are meeting the government suggested amount of exercise. It's 15% for men and 11% for women. And these are not they're not crazy. It's 2.5 to 5 hours of moderate intensity each week. So we're not exercising. Well, maybe we don't have time. Here's the amount of leisure time that we have. For those of us between 65 and 75, we have roughly 7 hours of leisure time per day. We have 8 hours over age 75. How do we use it? What is the number one use of our leisure time? TV. 60% of our leisure time is spent sitting in front of the TV with the remote. Less than 5% of our leisure time is spent doing exercise. And I would suggest to you that we need to exercise more than our thumb. I don't care what you do something. Walking is free. It's cheap. Get off the couch. Additionally, we need to reduce falls and do simple things to reduce falls. Night lights, handrails, get rid of throw rugs, put things in the cupboard so they're here, not up here. Do simple things to reduce falls. And secondly, one of the caveats of human life, I believe, is that with advancing age, we're supposed to get wisdom. Use that wisdom. So don't think you're 25 and don't be stupid. So here's a guy about my age out here in the snow up to his waist using a chainsaw. Here's somebody walking on a tightrope. Here's somebody going up on a roof. And because I'm from Wisconsin, I love the Green Bay Packers. And I would remind you that this guy, Max McGee, an all-pro wide receiver, died because he didn't listen to his wife and went up on the roof to clean off the leaves and fell and died. Use your head. We're not 25. And continue to do simple things. A friend of mine used to run a falls clinic. He thought that the most cost-effective thing he did was encourage people to go to the dollar store and get 10 pairs of these reading glasses. Because when you've got your bifocals on, you don't know where the edge of the step is here. So have these liberally sprinkled around your house. Here's a study that a friend of mine from the Marshfield Clinic did, Fergus McKiernan, and these creepers, wearing them in the northern Wisconsin winter reduce falls risk by 87%. That means that you have to have 6 people use them to reduce an injurious fall. Nothing has a number of 6 to treat it. It works. It's simple. Additionally, it's easy for those of us with gray hair to get on a multitude of medications. When you see your primary care provider, ask her or him, do I need all these drugs? Because I'm wondering about falls, I'm wondering about my balance, and a lot of our medications can cause drowsiness, dizziness, and difficulty with our balance. And that can also occur with over-the-counter medications. So look at all the drugs that we're on, and also remember that age 21, we knew that alcohol caused us to fall over. At age 71, it still does. So remember that alcohol feeding into this can cause us to fall over. Further, appreciate that osteoarthritis increases our risk for falls and fractures. These are the data. I'm not going to go through it. The point I want to make here is that gait assist devices can help us not fall over when we've got osteoarthritis. When you've got a bad joint and you put weight on it, things don't go well sometimes. Use the gait assist devices. And finally, after this, we're going to be doing Tai Chi. Tai Chi works. This is a meta-analysis. Again, I'm not going to go through the data, but Tai Chi improves our balance, reduces falls risk. Do it. There's a whole flock of good falls risk reduction resources out there. There's information at the table from the osteoporosis research program in there. I'm not going to go through these. You can find these online. Do something. Now, you've fallen, you've broken a bone. Ask if something should be done. And I would encourage you not to believe the quote here. Doc, anybody would have broke if they felt like I did. My bones are normal. No. I've heard that 1,000,006 times, and it's wrong. And why do I say that with such certainty? Here's data from a study that we did with Bill Leslie in Manitoba, where we linked the bone density data with the clinical outcomes. And we said, is the bone normal? And among the folks who subsequently broke, the bone was normal, these little green bars here, in practically nobody. So if you fall over and break at age 60 or 70 or 80, that wouldn't have happened at age 20 or 30. The bones are not normal. That means that we need to have a clinical evaluation, and that includes blood tests. We need to make sure nothing else is going on. And we need to get a bone density measurement. And this is simply an example of our standard DEXA scan, spine, hip, and wrist. It is a radiation exposure tool, and I can't stand up here and tell you that radiation is good for you, but it's a tiny amount. The amount of radiation you get getting this test is about the amount of radiation that you get flying from here to Minneapolis and back. And so it's a very, very low radiation exposure test. When you get it done, you're going to get numbers. Do not be confused by the numbers. So they came up in 1994 with this funky scoring system using a thing called the T-score. It's a negative number system, and if you're between -1 to -2.5, they called it osteopenia, which is a $95 word for borderline. -2.5 or worse, they called osteoporosis. We use it, but what's much more important is fracture risk. We care about fracture risk. We don't necessarily care about the T-score number. How do you know your fracture risk? You use a calculator. This is the calculator that has conquered the planet. It's called FRAX, F-R-A-X. I don't know why they called it that, but it's out there. Google FRAX and you'll find it. It's easy for you to figure out your fracture risk if you've had a bone density test. And you just fill in the boxes here and you push calculate and you get the number that says my 10-year risk in this case is 7.6%, which is low risk. So not just knowing your T-score, but know your fracture risk, because that's what's important. And then, what do? So if you've got low bone density and fracture, it's important to optimize calcium and vitamin D, but it's really easy to be confused by what we hear in the news, because what we hear today is different from tomorrow. Why is that? Well, I think St. Vincent Lombardi had it right, and this is a quote from Vince from 1935. And he feared that universities were deteriorating into incoherence with emphasis on uninterpreted fact instead of fundamental principles. And that's what our guidelines are becoming. They're becoming these rigorous meta-analysis driven guidelines with no thought behind them. What do the randomized controlled trials say? And when the RCTs, when the randomized controlled trials are flawed, the guidelines are flawed. And that has led to statements like this. I've heard that calcium supplements cause blood vessel calcification and heart attack. And that's because we didn't listen to Professor Haney. And he told us 10 years ago that you have to study people who are deficient in whatever nutrient you're studying. And so if you're deficient, then increasing the intake will improve the benefit. If you've got enough, you got enough. You don't need more, and it won't do anything. And if you've got a lot, giving you more can cause one thing, and that's toxicity. And in his usual way, he went on to say, well, duh, this is so obvious that one should thought it would go without saying. But it's not. And studies continue to be done that include volunteers with an adequate amount of nutrient X, in this case calcium and vitamin D, and then we give more of that nutrient, and as such they cannot show us what happens when we treat folks who are deficient. This is a fatal flaw, and as such our guidelines are flawed. What do? Well, I think we apply common sense. And as I understand it, our genetics, yours and mine, are not really different than these people who were hunter-gatherers. And there are people who have said, therefore, we should use the hunter-gatherer diet as at least some guidance on what we might take for our diet. And people have looked at the hunter-gatherers, and they got about 1,600 to 800 milligrams daily. How did they do that? They ate everything in sight. So that 1,600 is pretty close to our 1,000 to 1,200 milligrams recommended intake. How do you know what your calcium intake is? It ain't hard. Go to the IOF calcium calculator. IOF stands for International Osteoporosis Foundation. If you Google IOF calcium calculator, it will take you to this calculator. I like it because it's got a lot more foods. It doesn't just say, are you drinking milk, are you eating cheese? And you enter that, and at the end of the day, it's going to give you your average calcium intake and your recommended calcium intake. And then you can look at that and say, well, if I'm not getting to the recommendation, can I eat more of food X, Y, or Z to get to that? And if I can't eat more of food X, Y, or Z, then I need to take a calcium supplement to get there. It's easy to do. Let's move to vitamin D. Humans are supposed to live outdoors. We are supposed to make vitamin D when the sun hits our skin. Here in Wisconsin, we can't do that from roughly October, November through February, March. This is a study from Boston. Boston is a little bit south of the southern border of the state. And in the wintertime, no vitamin D is synthesized in the skin. Why is that? It's because the sun's rays are so low that all of the ultraviolet B is absorbed in the atmosphere. I often say that if you go cross-country skiing naked, you can't make any vitamin D. This was the most fun research study I've ever done. We went out and recruited kids off their surfboards in Honolulu. And we said, what was their vitamin D? And on average, it was about 40 nanograms per mil. That's the number that I think we should shoot for. And that often requires us to take 1,000 to 2,000 international units of vitamin D3 daily. The big brains in the field say that we need more protein to maintain our muscle function. That is controversial. The numbers that they're currently coming up with are really high, 1 to 1.2 grams per kilo per day. That's a lot of protein. I don't know where to stand on protein right now, but I think that it is important that we at least get some. Now, let's talk a little bit about over-the-counter supplements. Do they work? I'm seeing more and more information, or more and more interest in vitamin K, which I find fascinating because we published this study now 15 years ago that says it doesn't do anything for the bone. And there was a similar study done out of Tufts and one out of Toronto, but nonetheless, there's a lot of stuff still out there about vitamin K. I don't believe it does anything. I don't think it harms you, but I don't think it helps. How about strontium? There's a lot of interest in strontium. There was a time that I knew the periodic table of the elements. That time is long past. But strontium is just south of calcium on the periodic table. It's a heavier element. It's deposited into the bone. And because it's a heavier element, it absorbs more X-ray and it makes the bones look more dense. Is that good? I don't know. Strontium moronolate, a prescription, was on the market in Europe. It was pulled because of skin and cardiovascular toxicity. So I don't know if the same risks occur with over-the-counter strontium citrate. I don't know if that higher BMD number translates into fracture risk reduction. And because I don't know, I encourage you not to take it. Now, it would make sense that testosterone would be good, particularly for those of us with a Y chromosome. It should increase muscle strength and it should increase bone mass. And there's a multitude of testosterone boosters out there that encourage you to take them. And one of the encouragements is this questionnaire called the ADAM questionnaire, androgen deprivation in the aging male. And if you get 3 of these, you're supposed to take a testosterone booster. What are they? Well, low libido, yep. Lack energy, yep. Decreased strength, yep. Height loss, yep. My favorite one is, are you grumpy? Damn straight I'm grumpy, you know? So this is a way of selling testosterone boosters, and they're succeeding. This is a $73 million market in the United States, and this has recently been looked at. And they basically, these authors looked at 50 testosterone boosting supplements and concluded that they don't work, and it's certainly not a supplement for healthy lifestyle. Harvard takes it even a little bit further and says, don't waste your time on dietary supplements because they show little, if any, evidence of benefit. And I'd remind you that sometimes the over-the-counter supplements contain a boatload of what's in there. And more is not always better. And here's a wonderful, elegant study out of Calgary documenting that higher doses of vitamin D caused bone loss. And water is generally viewed as a pretty benign fluid, but every year we hear of somebody dying from water intoxication. So you can get too much of a good thing. So if you elect to take supplements, number one, first, make sure you're not breaking the bank. You can spend a lot of money on them. And secondly, discuss the supplements with your healthcare provider. So if you've broken a bone, and if you have high estimated fracture risk, I encourage you to consider an osteoporosis medication. But I think the first response that I often hear is, I've heard so much bad about those medications. And you do hear a lot bad about that, and I think some of it is reporting bad news. Here's a colleague of mine from Albuquerque, Dr. Lewicki, published this now a few years ago, and he said touting rare side effects has become a popular media pastime. It strikes fear and distrust in the hearts of patients. It's not good science. It doesn't contribute to good care. I think the osteoporosis drugs suffer from that. I think a lot of our medicines suffer from that. And I show you as an example acetaminophen. And here's some headlines that I pulled from the internet that basically says acetaminophen causes liver damage. Well, I learned that in medical school in 1975. I didn't think that that was really news, but it made these headlines, and because of that, I actually went and read the FDA document, and what did it say? Well, it says it's one of the most commonly used medications, and when used according to label directions, it has a well-established record of safety and efficacy. So that conclusion got translated into headlines that said this is a bad medication. I like quotes. All of you will recognize this guy. I think that Walter had it right. In seeking the truth, you need to get both sides of the story. We need to consider our risk for fracture, which is why we need to know our fracture risk, and we need to balance that against the risks of the medications. And in nearly closing, I want to share with you some insight into how our medicines work. And basically, they tinker with bone remodeling. And you and I have got bone remodeling going on right now, literally at 1 million places throughout our skeleton. And it's a very stereotyped process where we dig little holes in the bone and we fill them back in. And to me, that looks just like the process that goes on with what I call highway remodeling, and that occurs when there's a crack in the interstate. So there's a crack in the interstate. What happens? The road crews come in, they jackhammer out the crack, they clean it up all nice, the foreman gets on the phone to the concrete gang, they bring in concrete, and the highway's patched. And this is what bone remodeling looks like when we're 25. Just like the highways, it works perfectly. As we get older, either we dig the hole too deep, or the concrete crew takes the afternoon off. And we have bone loss, and this is going on throughout our skeleton, and ultimately then osteoporosis is due to malfunction of our road crews, and as such our medicines work on the road crews. And we now do have medications that actually bring in a bigger load of concrete. We can actually stimulate new bone formation. I'd encourage you to at least think about that and talk to your healthcare provider about it. So in summary, musculoskeletal status does generally decline with advancing age because stuff happens to us. But we can do something about it, and exercise and balance training is right at the top of the list to I think it's Nike, just do it. Get off the couch. Don't ignore falls. Eat a balanced diet. Know what your calcium intake is, and if you need a supplement to get to about 1,200. Recognize that we're not living outdoors and we live in Wisconsin, and take some vitamin D. Fractures threaten our independence. I can't emphasize that enough. The word is independence, and it's not just I fell, we need to evaluate you. Know your fracture risk if it's high. Discuss bone medicines with your provider, and I thank you.